I think much of what I wanted to say has been already so very well explained by Helena and Rob. But I thought I will spend a little time for a predominantly gynecological audience about what the metabolic syndrome actually means and how it impacts on our day-to-day management of our patients. I think you are all familiar with the apple and the pear concept of central obesity versus more fat laden around the hips. But I would like to take you back to this slide, which came out of the third PCOS consensus group, which clearly showed that the metabolic problems are lifelong and go beyond the reproductive age and the time that the gynecologist attends, but that the fact that this has to be addressed from the time of the woman being in her younger age. I think this is an important meta-analysis of overweight, obesity and central obesity in PCOS by the same group who have been speaking to you just now. And the fact that obesity and overweight would worsen the hyperandrogenism, menstrual irregularity, as well as the psychological problems of PCOS. And the fact that these women are more at risk of central obesity in general. I mean, we agreed even in the morning about the South Asian propensity, and the fact that this worsens the endocrine, metabolic and reproductive features. So to take you back to the concept of this metabolic syndrome, if you forget PCOS as a rule, it is clear that central obesity is the beginning of the problem. It leads to insulin resistance hyperinsulinemia, which causes not only effects on glucose metabolism, dyslipidemias, which includes elevated triglycerides, elevated small dense low density lipoproteins, elevated free fatty acids, low HDLs and fatty liver. While hemodynamically, they are more liable to sodium retention hypertension as well as elevated sympathetic activity, which probably has not really been addressed in most research, and the procoagulant, pro-inflammatory, which Rob showed even from the genetic point of view. But we need to appreciate that the metabolic syndrome, the cornerstone for its pathogenesis is central obesity. And this is an important slide which clearly shows that the pieces of the jigsaw puzzle actually fit in. And if you put in some kind of corrective action to bring down the abdominal obesity, all these factors get turned towards an improved status. Therefore, the WHO and many big organizations would encourage in the management of diabetes and pre-diabetes to take the multiple risk factor approach. You don't just treat the insulin resistance, but address smoking, the elevated lipids, the elevated blood pressures, as much as the glucose, and of course the inflammatory response, which has also been addressed. So on a day-to-day basis, when you see your patient, just as much as you need to measure the anthropometry of waist circumference and probably BMI, you need to check their blood pressures. They may be young people, but don't overlook that. Check for the history of smoking, because unless you really ask, they may not tell you. And as well as at least once that many years to check their lipid profiles, and no doubt the blood glucose. And this is also a very important set of data, that the more risk factors you have of metabolic syndrome, the cardiovascular outcomes increase by several fold. And this, when it is combined with type 2 diabetes, the increase in the risks of cardiovascular outcomes are that much more. So getting back to my patient, Miss Sri Lanka, who's 28 years, 6 months before marriage. As you remember, she had a high BMI, impaired glucose tolerance. Her 2-hour value was 168. Her blood pressure is 130/85, which in fact is pre-hypertensive, and she had lipid abnormalities. So that basically constitutes the syndrome of what we call the metabolic syndrome, as well as the fatty liver, which also seems to be an add-on. She's a non-smoker. She favors vegetarianism. I believe you all have much more vegetarianism than in our country, but the fact that they take more carbohydrates is an aspect that needs to be addressed, though it's very difficult. So you need to address them to take more in the form of legumes rather than pure starch. The next is that both her parents are diabetic. Her father had died of an acute myocardial infarct below the age of 60, which is considered a premature death due to chronic NCDs or non-communicable disease. And her question is, can I get diabetes and heart attacks like my father, and can I prevent this? So just to remind ourselves that PCOS is in fact a metabolic syndrome like condition. And in fact, if you look at the type 2 diabetes risk factors, thankfully PCOS is there on the list. But sometimes, I'm afraid, most epidemiological studies seem to have overlooked when they were looking at diabetes to look at the PCOS aspect in women. So we know it shares clinical and metabolic manifestations, and the fact that prevalence of metabolic syndrome in PCOS is estimated to be two times greater than the general population. Now, how do we define it? There has been a lot of changes over time. Initially, no doubt, hyperinsulinemia was the main feature, which we'll be discussing tomorrow morning. And it was in and around the hyperinsulinemia or insulin resistance as WHO defined. But these have become difficult to adopt. And what the American definition of the cholesterol prevention program, NCEP, ATP3 guidelines says any 3 of the 5 criteria, which is waist circumference, which for Asians is 90 and 80 centimeters, so 80 centimeters for women, which is pretty low. Hyperglycemia, which is a fasting blood glucose over 100, not 126. Triglycerides at 150 cutoff. HDL for women to be less than 50 being abnormal, and hypertension at 130 by 85. And that did not hold the central obesity to be an essential part, whereas the IDF classification clearly says that there has to be central obesity and any 2 of the other 4 criteria. Now, this is something that is difficult in a gynae setting, but I would really appreciate if this kind of concept is also taken into account in your long-term management of these patients. Obviously, Miss Sri Lanka's issues have to be time appropriate. At the moment, before getting married, she wants to regularize her periods and address her cosmetics, but she clearly needs to give due attention to her metabolic issues, particularly impaired glucose tolerance, her lipids, her blood pressure, and weight loss. And of course, the psychosocial issues. So we have been well addressed about the importance of counseling, and it is very easy to shove this problem, which is a chronic need, to one of your allied health professionals. But I think in our part of the world, they still hold the attending doctor in high esteem, and it's important that you address some of these on a continual basis just as much as referring. And of course, the question about metformin keeps coming up, and I think that will be addressed in due course. So as Helena said, it's not a large amount of weight that you want, depending on whatever the baseline BMI is. You try to address at least 5 to 7% and maintain it. And therefore, you cannot overestimate the importance of counseling. And its impact on menses and fertility has been so well addressed, I don't think I need to address that anymore. And also, I would like to encourage you to think of having a preconception counseling checklist, including rubella immunity, which often can get overlooked. So, in this context, if I went back to some of our own data from the clinic, you can see that the obesity was evident, but at a cutoff of over 25 as we used it. And depending on the type of the subphenotype, it did not matter. No doubt obesity was less, but the metabolic syndrome was as much. And what were the key features that we found in of the metabolic syndrome in these women was HDL being low was very common, as much as the waist circumference, and of course the BMI over 25, but if we went higher, then it was much less, the cutoff. Whereas impaired fasting glucose was prevalent in about 10%, when abnormal glucose tolerance in overall with diabetes to be that much. And hypertension was much commoner than the abnormal glucose tolerance. And the overall prevalence of metabolic syndrome in this clinic cohort was 30% at a mean age of 25. And what was interesting was 3 of the 5 diagnostic criteria by the American classification, NCEP, was present in this 30%, while an additional 57% had 2 of the criteria. So that was quite frightening. Of course, these were clinic attendees. And when we looked at their BMI at different cutoffs, simply because I was facing a lot of resistance about having different cutoffs, this was a couple of years ago, and you can see at 25 we had 51%, but as we increased the BMI cutoff, the prevalence became less. And similarly, for central obesity, whichever cutoff we used, there were slightly varying cutoffs. For NCEP, it was 88 for Asian women. You can see that it was generally comparable. Acanthosis was evident, as I mentioned earlier, but what was even more important was that of this 30% of women with metabolic syndrome, the impaired glucose tolerance was almost double in those with the metabolic syndrome, and the prevalence of type 2 diabetes detected by GTT was 10 times more. So, if we look at, this is what I was mentioning, although the obesity was less in the women who had regular cycles but were hyperandrogenic, it was very clear that whichever criteria which you applied, the American or the IDF criteria to diagnose metabolic syndrome, it was similar in the 4 subgroups. So just to recap about abnormal glucose tolerance, the conversion rate has been reported by Rob and others, but when we looked at our data as to what could be the associations, it is very evident that the odds ratios were significantly more for all these, with waist circumference, BMI, diastolic blood pressure, triglycerides being high, HDL being low, insulin fasting being high, testosterone more, odds ratios of metabolic syndrome was that much higher. And when we did a logistic regression, which kind of tried to tell us what were the determinants, it was very clear that as women age, their risk of the metabolic syndrome increased, pre-existing diabetes increased the risk, so did acanthosis, BMI at a cutoff of 25, and as much as the high insulins in the fasting state. So when Mrs. Sri Lanka inquires about her long-term fertility, when she has now got married and she's 6 months without conception, she still has weight excess, and the priority needs to address her fertility is, I think you would agree, is predominantly metabolic corrections plus sustained weight loss of at least 5 to 7%, of course with folate supplements and good blood glucose control, and to look for end organ dysfunction at the same time. So once again, counseling, lifestyle modifications are the most important, while metformin, inositol, not statins, I wouldn't really get on to statins, and sometimes the expensive treatments of orlistat and other weight reducing drugs. She's 18 months married now. did not use any contraceptive. She has dealt with her situation to a reasonable degree of satisfaction. Her skin color also has improved in the nape of her neck. And what are her possible options? I'm sure it will be addressed tomorrow, but I just wanted to remind you that we often forget the husband, and very often he doesn't even come with her, and we need to insist on encouraging him to check himself out as well. So getting back to the metabolic syndrome, about weight. This was an interesting global health set of data that I came across, that these are the countries that have gained weight, and unfortunately we are right on top, South Asia, as opposed to some of those countries that have not really gained weight over a period of time from 1980 to 2005. So there is no effective preventive option beyond lifestyle-based interventions, as has been shown by many a study, and which had been very beautifully reviewed by nutritional reviews. And if you were to take reasonable measures to prevent or delay the onset of metabolic syndrome and prevent the expected outcomes if you don't control, that is cardiovascular disease and type 2 diabetes, it is very clear that lifestyle modification at population level is the most important. So, as Helena said, calorie restriction, increased physical activity, and behavior modification. And this was something I learned from my colleagues in the psychological department, who seem to have a much better idea about how to change the behavior of people than what you and I do on a one-to-one basis. And the fact that physical activity, at least 30 minutes with gradual increase in high-risk patients, to check them out for cardiovascular evaluation, and to encourage whatever physical activity in their daily living, as Helena pointed out. The other important aspect is smoking and alcohol, as much as trans fat and salt consumption. I do not know the Indian data, but for Sri Lanka, while the daily consumption that is considered healthy is less than 5 grams of salt, which is table salt in 1 teaspoon, our local data shows that an average person eats about 12.5 grams of salt per day. So I think some kind of collective action of reducing salt consumption, which we may not even think about, and that often comes from processed foods, just as much as tobacco and alcohol taxes, and you need, as Helena said, bold and creative policies. So some aspect, we don't really take smoking as important, and we might not even ask from the Asian woman whether she smokes, and unless you ask, she won't volunteer the information. The smokers, smoking has been closely linked to the metabolic syndrome, and smoking cessation has to be addressed just as much as passive smoking due to the partner smoking. Similarly, physical activity has been shown to be of great benefit at level A evidence that it has substantial effects on metabolic syndrome, as much as a healthy diet to achieve at least 5% weight loss. Alcohol is considered harmful, just like what was mentioned earlier. There was a lot of lobbying by the industry, even at very high level, about beer being protective and so on and so forth, and that has to be clearly, it aims at encouraging the young to start taking alcohol, and that has to be completely addressed by people like us from the healthcare profession. So as Helena said, if you reduce or restrict the calories by 500 kilocalories for a day, that would equate to about a pound per week of weight loss. And obviously this will be rapid at the beginning, and the importance is to encourage them to adhere to the diet. And what we do is we encourage them and give them a broad overview about what they should adopt, the principles of the nutrition. And one is the regular meals, best meal to be at breakfast rather than dinner. We say to give away, to share their lunch and to give away their dinner to the enemy. And similarly, to follow a plate model where you just turn that letter T, capital T, sideways and say only a quarter of your plate to have starch-based meals, whereas the rest should be vegetables and some kind of protein, which usually is fish or chicken, or in the case of a vegetarian, to use soya-based food. And the importance of having so many numbers, say about 5 colors of fruits and vegetables for a day, but we need to mention the quantities. I have come across many, a man and a woman, who think fruits are good and they eat a comb of bananas rather than a single banana. They would take very ripe fruit, which is full of sugar, rather than partially ripe. So these should be specified. And just as much as we send them to the dietitian, I think we clinicians also need to show them that we also respect these issues. So what has been very clearly shown is that a 2-year change in lifestyle risk factors in those with incident metabolic syndrome in large community trials showed that an increased body weight and alcohol intake with decreased fruit and vegetable consumption were the main odds for incident metabolic syndrome. So I won't take more of your time, because I know you all are all tired and probably need more physical activity. But PCOS is closely linked with metabolic syndrome, needs active screening, and the detection means we need to take appropriate preventive action on a one-to-one basis, address non-alcoholic fatty liver disease, although obstructive sleep apnea also probably needs attention but goes well beyond our scope here. And the multiple risk factor approach, like from smoking to blood pressure assessment and addressing salt intake, also needs to be addressed, and the fact that we have to take a life cycle approach, because these are women who have come to reproduce and we don't want PCOS to beget PCOS. Thank you very much.